Hello and welcome. My name is Till Stürmer. I'm from the University of North Carolina at Chapel Hill. This is the workshop Selection Matters, Addressing Biases in Linked Clinico-genomic Datasets. I'll quickly go through the speakers and then we'll start the session. First is Dr. Catherine Panagis from Memorial Sloan Kettering Cancer Center, and she will set the stage. Then we have Dr. Ken Kale from Dana-Farber Cancer Institute, and he will talk about the extent of left truncation using a specific example. And then we have Dr. Devin Inserti from Roche and Genentech, and he will talk about how to quantify and address potential selection bias due to left truncation. So, and we will then conclude with a panel discussion moderated by myself, and I hope we have enough time for that. So without further ado, Dr. Panagis, please.
Great. Thank you for the introduction, and thank you for Devin for organizing this session, and to Ken and for participating, and Till for being the discussant here today. As was stated, we've organized this session with my talk as more of an introduction to the problem in these observational data sets. And then we move on to more complexities and specific issues with Dr. Teal and Inserti's talks. So I'll start out by just reviewing some existing databases that we've worked very closely with over the past few years, and that are becoming increasingly more common. So there have been numerous genomic data sets that have been made publicly available in the field of oncology. To date, most of these have had limited clinical information attached to the genomic data. But in my talk, I will look at the effect of left truncation in the context of this one particular research program. It's based on the American Association for Cancer Research, the AACR Project Genie, which is a publicly accessible international cancer registry of real-world data assembled through data sharing among 19 of the leading cancer centers in the world. And as part of this program, Genie aggregates, harmonizes, and links next-generation sequencing cancer genomic data to clinical outcomes such as overall survival. And these data in many of these linked databases have been limited. They've had limited clinical information with approximately 10 clinical variables. And as part of this next generation, if you will, of creating these databases, there's been an extension to this AACR Project Genie, which is the Genie BPC initiative. And the goal of the Project Genie BPC, which is a biopharma collaborative, is to augment the existing data in Genie, the original Genie data program, with significantly enhanced clinical or phenomic data. And these phenomic data are curated using what's called the PRISM curation model. And PRISM is a standard taxonomy for classification and communication of structured data from the electronic health record about cancer status and treatment outcomes following the assignment of cancer stage in these patients. So currently, Memorial Sloan Kettering, Dana-Farber, Vanderbilt, University Health Network at Toronto are the participating institutions. And going forward, Genie BPC will expand to many more institutions similar to the original Genie project. And we have incredible amounts of clinical data attached to the genomic data. So we've got probably about 700 clinical variables in this linked database. And there are 6 cancer sites that have been curated using this PRISM model. And they're non-small cell lung cancer, colorectal cancer, breast, pancreas, prostate, and bladder. And the unique component of this Project Genie BPC is that the data will be publicly available. It'll be released at specific time points for each of these 6 cancer sites with all of the de-identified clinical data will be publicly released over the next 3 years. So there will be access to significant observational data with genomic data. This is extremely unique. And in using these data, there's the availability of really looking at treatment exposures and survival outcomes with genomic data in order to advance precision oncology and translational research. So what kinds of questions can we answer using these cancer cohorts? By combining the drug regimen data with start and stop dates and attaching it to the genomic data, we have opportunities to investigate a wide range of analytical questions and time to event analyses. We can look at questions using the Gini-BPC data. Some examples are how do oral targeted therapies affect progression-free survival or overall survival in specific cohorts, specific stages. How does overall survival from the start of a regimen or an immunotherapy or targeted therapy compare to overall survival from start of an alternative regimen within a specific cohort? So use of these observational clinical genomic data sources for survival analyses requires an understanding of the data and the potential inherent biases, which is really the focus of this session today. And we'll talk mostly about delayed entry. So an underlying assumption of survival analysis is that the time of study entry and the time of origin, such as diagnosis or start of regimen, are aligned. And this is typically the case in clinical trials, where a patient would enter a study at the time origin of interest, maybe the start of a treatment regimen. But when we're looking at these observational data, this alignment of the study entry time and the time of origin for your analysis may not always be aligned. And this is because in clinical practice, in these clinical genomic studies where time of study entry is oftentimes your molecular tumor profiling, genomic sequencing results are obtained after the start time for survival estimation. So tumor profiling is expensive and is not always indicated for patients with cancer of all stages. So at a certain point, patients may get their tumor profiled, and this time point may not necessarily align with the index time that you'd like to estimate your survival analysis. And in the Gini-BPC data, patients were selected for entry into the study if they had genomic profiling performed within the years of 2015 to 2017. So when we look at the time from diagnosis to sequencing, if we take a particular cohort, stage 1 through 3 of non-small cell lung cancer patients, the interquartile range of the time from diagnosis to sequencing was 1.5 to 12.4 months. So for 25% of the cohort, there was at least 1 year from diagnosis to sequencing. Similarly, for stage 4, while it was shorter, but overall survival is also shorter, the interquartile range was from 1.4 to 7.8 months. So at least 25% of the cohort had their sequencing 7.8 months from the time of diagnosis of their stage 4 non-small cell lung cancer. So what does this, because this was a design criteria, how does this impact your survival estimation? So delayed entry is the time of origin, when your time of origin occurs after your time of study entry. So just reviewing some of the terms. So this results in left truncated data. That is, patients had to survive long enough to undergo genomic sequencing to be included in our Gini-BPC cohort. Further, this means that those who did not undergo sequencing were never even considered for conclusion into the Gini-BPC. So patients who died are not even included because they didn't have their their tumor sequenced. They didn't live long enough to have their tumor profiled. So left truncated data creates an opportunity for length bias, which in turn results in bias and specifically an overestimation of our survival estimates. And we'll just demonstrate this more closely in the coming slides. And basically, we have an enriched cohort because you needed to live long enough by design to have your tumor profiled between the years of 2015 and 2017. So, sorry about that. Delayed entry or staggered entry is not a new problem in statistics, in the field of statistics. Left truncation adjustment methods have been around, and the appropriate, statistical methodology to account for delayed entry, really there's many different approaches, and they're well established throughout the statistical literature. In these clinical genomic studies, however, the methodology often goes underutilized, and in many genomic clinical genomic studies that have been published, we have found that there has been no adjustment for left truncation and accounting for this staggered or delayed entry into the cohort. In these left truncation methods, at least some of the simpler ones, can easily be implemented in standard software such as R and SAS. And I'll really walk through the risk adjustment approach. So just to better visualize what we mean by delayed entry, we look at a typical survival analysis where we might want to estimate from the date of diagnosis. We're interested in the time of diagnosis and time of death or censorship. And in Gini BPC, 100% of patients had date of sequencing after their date of diagnosis. As we said, that was by design of the cohort curation. So we know that to be included in the cohort, patients needed to live until their date of sequencing. Therefore, the time between diagnosis and sequencing, or the period of delayed entry, is where we have this left truncated data. And this time interval must be left truncated. For overall survival from the start of treatment regimen, which is maybe an alternative starting point for survival analyses, especially when we have all of these treatment regimens curated for these 6 cancer cohorts. Some patients may have undergone sequencing after beginning the regimen of interest. And similarly to survival from diagnosis, this period must be accounted for using left truncation. So when we're estimating overall survival from start of treatment regimen, we see that this blue block of time from the date of start of regimen to the date of genomic sequencing is where we also have left truncation in that scenario. So I'd like to just walk through and give really a very simple example. So if we took a patient who was diagnosed with stage 4 non-small cell lung cancer on January 1st, 2014, and who dies on January 1st, 2020, this patient lives for 6 years from diagnosis. Additionally, this patient undergoes genomic sequencing on July 1st, 2015, or a year and a half after their diagnosis. And that allows them to be included in this observational clinical genomic cohort. We know that the patient must have survived at least 1.5 years past diagnosis to be included in the cohort. But they enter the study on July 1st, 2015. So this interval between diagnosis and sequencing is left truncated, meaning that we don't account for them being in the study until that 1.5-year time point when they entered due to genomic sequencing. In this way, the patient enters the study at year 1.5, while still having an overall survival time from diagnosis at 6 years, such that they exit the study at time 6 years. Here we present 2 figures, an event history plot on the left and overall survival curve from diagnosis of a different cohort, stage 4 pancreatic cancer from diagnosis. And I'd like to demonstrate the impact of left truncation on survival estimation using these two figures. So these event history plots, the event history plot on the left illustrates the patient's survival times. Each patient's interval from diagnosis to time of genomic sequencing is shown in black, while their time interval from sequencing to death or end of follow-up is shown in blue. So the distribution of black on each event history plot represents the magnitude of the delayed entry in the analytic cohort. So you can actually use an event history plot such as this to see to the extent you have delayed entry. And you can see that, you've got about, 25% or 30% of your cohort is at least entering 6 or 7 months later. And we see on the right the impact of accounting for left truncation in overall survival from diagnosis in this particular survival curve. So the black curve is the unadjusted survival distribution, where we ignore left truncation, and we see we have a median survival of 13.09 months. When we adjust for the delayed entry into the cohort, we have a median survival of 9.87 months. The unadjusted curves fall above the adjusted for delayed entry, which reflects the longer survival estimates when left truncation is not accounted for. And we said the patients are enriched for better survival because they needed to live long enough to have their genomic sequencing, and you actually see this in the unadjusted curve. So the cohort's enriched for survivors, but we like looking at this event history just to see the extent of, it's a little different way of visualizing the extent of delayed entry. So going back to our example patient from the previous slide, if we look at why there's overestimation, remember that the blue curve, the patient enters the risk set at year 1.5 as the patient underwent sequencing a year and a half after diagnosis. In the black curve, the patient enters the risk set at the time of diagnosis, or time 0, and is followed until they experience an event or is censored. In both curves, the patient leaves the risk set at time 6 years. So what confuses investigators a lot of times is that the number at risk on a survival curve does not necessarily decrease when you account for left truncation using a risk set adjustment method. So you see that for the black curve, which is unadjusted and is our ordinary Kaplan-Meier survival estimation, this results in a decreasing number of patients at risk over time. So 996 to 719, 511. All patients enter the risk set at time 0, and they decrease over time as patients die or are lost to follow-up. But we know we have staggered entry. So for the blue curve, where we adjusted for left truncation by adjusting for their entry time into the risk set, staggered entry results from varying times of sequencing leads to the number of patients at risk to not consistently decrease over time. So at time 0, we only had 53 patients included. That it's really not time 0, it's a little bit over, just because people had their sequencing a little bit after diagnosis. And then year 1, we had a 518, and then it goes down. But this risk set can go up and down depending on who's in and out due to the staggered entry. So the life tables here show the event right before and immediately after a patient's event at 6 years. So taking our same individual patient. The top table corresponds to the survival distribution that does not account for left truncation, ordinary Kaplan-Meier estimation, And the bottom table has been adjusted. So using a risk set adjustment approach that accounts for left truncation or the delayed entry into the study. In both cases, the number of events and the number censored are the same. However, the difference in number at risk leads to varying probabilities of survival. So we can see that your y-axis is adjusted when you follow this, and your number at risk will be adjusted. But your survival times and the events at particular survival times is the same. So because of the denominator in the risk set, the survival probability is adjusted. Here's another example of the event history plots using a different cohort. And I'm just showing this to show that the magnitude of left truncation in these cohorts can vary greatly by disease. These are colorectal cancer patients in stage 1 through 3 on the left panel and stage 4 on the right panel. And the black, which shows the delayed entry, is significantly more in than our pancreatic cancer cohort. And this will lead to even a greater overestimation when not adjusting for left truncation using either a risk adjusted approach or other approaches that will be discussed in future talks. So just a very naive approach that people have used in the literature is just to restrict analyses to patients who are not left truncated. But this really reduces the available sample sizes and may potentially introduce other selection biases. But we've seen this quite often in some of these studies. And just as an example, if we restricted the non-small cell cohort to only those who had genomic sequencing within 60 days of diagnosis, our sample size would be reduced by 60%. So you sort of, you lose all of the, aside from potentially introducing other biases, you lose the richness of these data sets. And we really advocate for, making adjustment for left truncation standard practice for these survival analyses and studies with delayed entry, just as we account for right censoring and standard time to event analyses. I mean, nobody argues about that. So we really are trying to highlight the problem, which is not a new problem, and really demonstrate that there are very simple approaches to handling these left truncated when it's a straightforward delayed entry problem. And then I just would like to show, obviously with caveats of patient eligibility, we walked through and compared estimates from our Gini BPC data that have been adjusted with left truncation with results from a clinical trial from Korea that was published in JAMA Oncology in 2015 that analyzed overall survival from start of first-line erlotinib among EGFR mutant stage 4 non-small cell lung cancer patients. And we found that the median overall survival of 29.1 months aligned with what the clinical trial found, which was a median of 31 months. We also looked at a second comparator, which was a trial published from Emory in the New England Journal of Medicine, also evaluated overall survival from the start of first-line erlotinib, and we found in median overall survival in the second comparator was 31.8 months. So the Gini BPC data accounting for left truncation aligned with this study as well. And when we did not adjust and we fit, ordinary Kaplan-Meier estimates and did not use a risk adjustment approach, the median overall survival was 40.8 months. So this is, again, this is a very crude look at some published data just to see how the adjusted estimates compare with what's published in the literature. Again, there's caveats, there's patients, comparison of patients within the clinical trial data, but to the best that we can in a crude approach, when we adjust using left truncation methods, we're much closer to what's published in clinical trials. So basically, in summary, These clinical genomic observational data sets are a valuable resource for evaluation of real-world cancer outcomes, and should be analyzed using appropriate methods to maximize their potential. We advocate analysts must become adept at application of appropriate statistical methods to ensure valid, meaningful, and generalizable research findings. And furthermore, many of these approaches are available in standard statistical software in R and SAS. Thank you. I think we'll save questions for the end. I'd like to acknowledge the entire AACR Genie coordinating center and collaborators from all of our institutions that have been participating in this huge effort. I will stop sharing.
Dr. Sturmer, I see you may be making some comments. I think you're muted.
That is definitely true. Thank you, Dr. Panagis. Dr. Kale.
Great. Just going to share my screen here. Okay. Hopefully this is visible to everybody. Let me know if not. Again, thanks for having me. So I'm a medical oncologist at Dana-Farber and a health services and informatics researcher here. And I'll be discussing some work we've done around the issue of informative left truncation in a clinico-genomic cancer data set. So I think Dr. Panagis has done a great job at describing the issue of left truncation in general and how we might address that, and describing the existing methods for addressing that. I think we'll now be diving into this next level of complexity around informative left truncation. I think it may be fair to say that the available toolkits for dealing with this problem are not as well developed so far. So to reiterate a little bit of what's been discussed, many of us are working with these clinico-genomic cancer data sets. And just to provide a little bit of kind of clinical context here, these are cohorts of patients with cancer whose tumors have undergone some degree of in-depth genomic sequencing. And really the goal of these data sets is to understand prognostic and predictive genomic patterns that we can use to try to drive precision oncology, namely giving patients treatments that are most likely to help with their particular cancers. And in creating these data sets, again, genomic sequencing is an eligibility criterion. I think notably, though, the criteria for genomic sequencing within each health system that might be contributing to a data set like this may vary. So often there's an element of physician selection. Doctors may decide whether and when to do genomic sequencing on their patients based on when they can get that testing approved or reimbursed by insurance, or when it's indicated to potentially select an FDA-approved treatment. In some contexts, genomic sequencing might be offered to all patients with advanced cancer. I think rarely it might be offered to all patients at diagnosis. I think that's actually quite rare. Sometimes it may be offered to all patients who walk in the door of a given cancer center, although patients may walk in that door at different points along their disease trajectories. In terms of selection biases in clinico-genomic data, I think there's one type of selection bias, which is fairly intuitive, namely that some types of patients might be more or less likely to make it into our data sets at all, and that may be due to clinical factors, sociodemographic factors, and others. But I'll be focusing on this issue that for purposes of discussing with clinicians, I've called temporal selection bias. It has traditional statistical names like informative left truncation or dependent left truncation, namely the issue that the timing of entry into a genomic data set may actually be correlated with clinical features, including risk for an event that may matter. So to try to illustrate these dynamics, I've basically diagrammed here a few different cancer trajectories, beginning with diagnosis. So one thing that can happen to a patient is that they may be diagnosed with a stage 4 metastatic cancer. They may then undergo tumor sequencing, next generation sequencing shortly after diagnosis, maybe because it's offered routinely to all patients with stage 4 disease. And at some point, they may get treated and then unfortunately experience cancer progression. Other patients may be diagnosed with early stage disease. They may have genomic sequencing right after diagnosis, maybe because they're in an academic cancer center that's offering that to all patients. And then they may eventually go on to experience cancer recurrence. A third potential trajectory is that a patient may be diagnosed with stage 4 disease, experience some treatment, eventually have cancer progression or worsening, and then have genomic sequencing requested by their doctor specifically because of that cancer progression, because what the doctor's doing is looking for information that might inform selection of the next treatment they might offer to the patient. Similarly, patients might be diagnosed with early stage disease, have some initial treatment, eventually the cancer may recur, and then they'll have next generation sequencing done essentially because of the cancer recurrence to try to drive treatment selection. And finally, a combination of the above dynamics might happen. A patient might be diagnosed with early stage disease, have some treatment, eventually have recurrence, have some treatment, eventually have progression, and then genomic sequencing is at that point ordered to try to inform treatment selection. I think for purposes of then going back and using the data generated on these patients to try to ask research questions, in some sense, these first couple of trajectories are sort of okay for analysis, more or less out of the box, potentially with adjustment for left truncation and the traditional risk set adjustment method that Dr. Panagis mentioned. But these, I think, latter 3 types of trajectories are a bit more problematic because essentially patients are entering our cohort at a time specifically because their cancer is worsening. They're at increased risk for an event at the moment when they're entering the cohort. Another way I've tried to think about this and discuss it is to think of these segments of time along a disease trajectory as immortal time, which we're somewhat used to thinking about as researchers using observational data. But then there is this potential for excessively mortal time if this issue of genomic sequencing because of cancer progression is operational in a data set. So obviously, if next generation sequencing is an eligibility criterion for a clinico-genomic cohort, then patients won't be experiencing mortality events prior to cohort entry. And dealing with this problem is largely that issue of traditional risk set adjustment for left truncation that we've heard about. However, if next generation sequencing is performed because of cancer worsening, then to some extent, this time after genomic sequencing captures a biased proportion of the disease trajectory that's at increased risk. So I think one challenge is that if we apply those traditional left truncation methods to analyze only the time at risk, which is after next generation sequencing, we might actually be biasing survival estimates towards a more pessimistic view because the resulting time at risk is more mortal, it's higher risk compared to the patient's overall trajectory. So what we sought to do, at least to inform some considerations around this problem, was to quantify the extent of dependent left truncation or temporal selection bias in a real data set. So we did a simple retrospective cohort study at our institution of patients with lung, breast, colorectal, pancreas, or urothelial cancer, whose tumors were genotyped from 2013 to 2017, and for whom we had cancer registry data available to ascertain the diagnosis date. And these patients had stages ranging from what's sometimes called stage 0 disease, so non-invasive or in situ disease, all the way through stage 4 disease. And there were just under 4,800 patients for analysis. And these are really the results. So what we did is calculate a statistic called the conditional Kendall-Tau statistic. And that's, as I think we'll hear shortly, one approach that's sometimes used to try to look for and quantify this dependent left truncation or informative left truncation or temporal selection bias. And it essentially, this statistic essentially represents a non-parametric correlation between the time from index or diagnosis to study entry or genomic sequencing and the time from index or diagnosis to event or mortality in this case. And we calculated that in the overall cohort of these patients and then broke it down by cancer stage as well as primary cancer site. And what we saw was that generally across the board, there was a negative correlation here indicating that the time from diagnosis or index to mortality was generally shorter than might be expected after accounting for the time from diagnosis to genomic sequencing, potentially indicating that essentially patients who have genomic testing late seem to be at a higher sort of shorter term mortality risk after genomic sequencing, which is what you might expect if physicians are essentially ordering genomic sequencing because of cancer worsening. This did vary somewhat by stage here. In particular, it seemed to be more operational for patients with early stage disease, stage 1 through 3 disease, and potentially not really operational for patients with stage 4 disease, at least in this cohort. And this, I think, is what you might expect if disproportionately patients with stage 4 disease have relatively unselected prompt genomic sequencing performed, whereas patients with early stage disease might have genomic sequencing performed only after they've gone on to develop recurrent disease. And we did see that this dynamic was present across cancer types as well. So I think in conclusion, dependent left truncation or this temporal selection bias is likely operational within clinico-genomic cancer databases and needs to be something that we think about. Though I think the extent of this problem for any practical research question probably varies by dynamics like cancer type, stage, and research question, particularly around what's the index time point. So we quantified this dynamic based on an index time point corresponding to diagnosis. It may well, at least sometimes, be less of an issue if we are, say, looking at an index time point that represents the first palliative intent treatment for advanced disease. I think another dynamic that we haven't addressed here or so far is how to think about these issues if we're using, for example, a progression-free survival endpoint, which is a composite of cancer worsening and mortality, because there the sort of dynamics at work get even more complicated, since patients might, for example, be able to experience cancer progression or worsening events even before they've had their genomic sequencing. But if there's informative left truncation or selection into the cohort, those progression events might be less likely early on before genomic sequencing. And meanwhile, they're also not vulnerable to actual mortality events during that early period. So I think the considerations here do get complex, and we haven't solved this problem in our work. We just sort of sought to quantify it. I think that's all I have.
Thank you very much, Dr. Kale. Again, let's keep questions for the podium discussion at the end and continue with Dr. Inserti.
Thank you. I'm just going to share my screen. Okay. So far we've had Dr. Panagis and Dr. Kell have given us some really nice examples of real data sets and analyses in those data sets, as well as some of the more complicated problems that might arise. What I'm going to try to do is I'm going to talk more generally about this type of data that we have, which I call left truncated and right censored survival data, and to think about it in the context of a little bit of a statistical framework for some specific inferential problems that we might want to answer. And to start, I think it's useful to think about exactly what we mean by left truncated and right censored survival data. And a lot of this will be a little bit of a review from what we've seen previously, especially by Dr. Panagis, maybe put a little bit differently. So in an ideal setting, we would have no censoring and we'd have no truncation. So here's an example of that type of simulated data with 1,000 simulated patients, and we observe everyone's actual survival time. So this would be great. This is what we would hope for. Of course, we don't actually get this. What we almost always have is right censoring. And when we have right censored data, that means we still observe the full cohort of 1,000 patients, but our outcome variable changes. So instead of observing everyone's actual survival time, we only observe their follow-up time, which is on the x-axis. And that means a certain proportion of the patients are right censored. That is, we don't know their true survival time, we only know their follow-up time. And there's standard methods, of course, to deal with right censoring. When we have left truncation, though, the problem is more severe in that now we don't actually observe the full cohort. So instead of observing 1,000 patients in this little simulated example, we now observe only around 600. So about 40% of the population is left truncated. And of course, the patients that are left truncated, or the patients that are more likely to be left truncated, are the ones that have shorter survival times. And what this does is it actually shifts our distribution. So we lose some of the follow-up times at the start of the earlier distribution, and we have a more longer follow-up time. So the distribution is kind of shifting to the right a little bit, if you will. And as you might expect, and as we saw previously, this can potentially cause an immortal time bias. And that happens because our cohort now only consists of the patients that survive until the entry date. And like we saw previously here, I think previously we looked at the time of origin and time to event from time of origin. Here I just call time of origin the index date. And we'll have study entry for when patients enter the study. And effectively, because of the left truncation, patients are immortal from the time of index date to the time of study entry, at least the patients in the cohort that we have. And as a kind of related note, I think it's important to distinguish left truncation from other potential causes of immortal time bias, and specifically other causes of immortal time bias in which the entire cohort is actually observed. And an example of this would be like a clinical trial, but measurement of a covariate such as genomic profiling happens after index date. And the reason to distinguish is because when we don't have the full sample, as in the left truncation case, it actually prevents us from using certain methods that we could use if we observe the full sample. And those include things like inverse probability weighting, time varying covariates, or even a landmark analysis. So as we saw previously, the standard approach with left truncated data is to modify the risk set. So just as a review, really what this means is that we're going to say that patients are only at risk following their study entry date. So in contrast to the standard right censoring approach where everyone's at risk following their index date or time of origin, such as a time of diagnosis. And what this means, again, is that we have what we call start-stop data, which can be analyzed specifically what's sometimes known as a counting process formulation. So a data set might look like the following. We have a patient's entry time, we have their follow-up time, and then we have a status indicator. So here 1 if an event happened, 0 if it didn't. And with this approach, we can use standard software. So here's an example from the survival package from R, where we do both Kaplan-Meier estimation and estimation of a Cox model. And the only difference from the standard approach is instead of now just having follow-up time and status or event status, we now have a triplet where we have add in the entry time as well. So we're kind of letting the software know that we have the start-stop data, and it knows to modify the risk set in the appropriate way. Now, an important assumption that Dr. Kell alluded to when we're doing this type of modification of the risk set is something called the quasi-independence assumption. And if this assumption is satisfied, then when we modify the risk set, we're in good shape. If we try to estimate survivor functions, like from a Kaplan-Meier estimator, or to estimate regression coefficients, such as from a Cox model, they're going to be unbiased when this assumption is satisfied. And what is this assumption? Well, specifically, it means that time to study entry and time to event are independent. And in particular, they're independent in what we call the observable region. And the observable region is just the region where the patients are not left truncated. So that's the patients we actually observe in the data set. In other words, the patients for which their entry times are actually less than their event times. And luckily, in a regression context, we actually need to assume something that's a little less stringent. We can assume what's called conditional quasi-independence. And that is quasi-independence within covariate strata. So in other words, we actually only need quasi-independence conditional on the covariates that we're controlling for in our model. Because the independence assumption is quasi, if you will, within the observable region, that means that it can be tested, like we saw with Dr. Kell, with the nice tests in different settings. And the most common test is probably what's called the conditional Kendall's tau, which we saw previously. And that's a nice test because it's non-parametric. And it's called conditional because it's essentially an extension of the standard Kendall's tau test to a scenario where we have right censoring. However, because it requires this right censoring adjustment to the traditional Kendall's tau, it does require some specialized software to be able to implement. Another approach, which is quite simple, is to simply use a Cox model. So using the formulation we saw before, where we have entry time, follow-up time, and event. So the modification of the risk set approach, and where we just have entry time on the right-hand side. And the nice thing about this approach is it can also be easily extended to incorporate covariates and to think about conditional quasi-independence as well as just quasi-independence. And under this approach, if we had, say, a significant entry time coefficient, then it would maybe provide us some evidence that there's going to be dependent truncation. And I think in practice, typically the Cox model and the Kendall's tau tests will produce pretty similar results. So that's what we found. So for the rest of my talk today, I really want to focus on two different types of inferential problems. So the first one is the common setting where we want to estimate hazard ratios with a Cox model, such as in maybe a causal inference type setting. And then second, turning away from estimation of the hazard ratio specifically, but toward prediction problems. And just because we've worked with penalized models before, I'll kind of do it in the penalized Cox setting, but there's really nothing that's specific to the penalized type of model. Okay, so starting with estimation of hazard ratios with the Cox model, I'm going to first introduce a simulation study, and we'll work with simulations for a couple of reasons. I think one, it's nice, it kind of helps us understand the left truncated data a little bit better and how it might arise. And second, it can help us characterize potential biases and the magnitudes of those biases. So what might a data generating process look like for left truncated and right censored data? Here we'll have a time to event, which we'll call T, a study entry E, and a right censoring C. And we'll assume that they're all drawn from proportional hazard models. So the first function on the top is just a model for time to right censoring. And this is really simple. So we have no covariates. We're just drawing right censoring from a distribution. The second equation where we have E, that's time to study entry. And the difference here is we now actually have covariates X that can be predictive of study entry. So you might think that certain covariates determine how long it takes us to enter the study. In a kind of a more applied setting, it could be how long it takes us to get a next generation sequencing test, for instance. And that means if we have our gamma not equal to 0, that just means covariates are associated with entry time. And then our final equation on the bottom, that's our main equation that we care about. So that's kind of the standard Cox type model. And here we have, again, our covariates X, and then we have our betas. So those are the betas that we would actually care about in a Cox model. And then we'll introduce a potential dependence between entry time and time to event T through this log E term. So essentially, we're just introducing the dependence between E and T. And what that means is that if rho is not equal to 0, then we actually have quasi-dependence. So our quasi-independence assumption is violated. And with this type of setup, we can then actually generate survival data specifically for our observed follow-up time, which we talked about before. So we'll say that follow-up time Y is just the minimum of our true time to event and our time to right censoring. That means the patient's right censored if their censoring time is less than their event time, and that they're left truncated if their time to study entry is greater than their follow-up time. And then to try to set ideas, make things a little more concrete, we'll conceptualize time to event as overall survival going forward. We'll assume for simplicity that the baseline hazards are exponentially distributed. Although in practice, I found that the results are not sensitive to this. And again, for simplicity, we'll just assume only one covariate. To try to put it in kind of a causal lens, we'll think about treatment assignment. So 1 being treatment, 0 being control. And then, of course, the degrees of bias will depend on certain characteristics of our data. So we're going to vary a couple of things. In particular, the association between the treatment assignment and entry time, that's our gamma. And also we'll consider 3 different truncation scenarios. So a low scenario where approximately 5% of patients are truncated, a medium scenario where 15% are truncated, and then a high scenario where 30% are truncated. And we'll fit 2 types of models. One, the risk set adjusted model, and then also where we don't adjust the risk set. And remember, our data for estimation is only where the follow-up time is going to be greater than our entry time. So the non-left truncated sample of patients. And here are some results from simulations. So looking at the bias in Cox models, assuming the quasi-independence assumption. So now we're assuming that the rho is 0. And what you see here is that if you do the risk set adjustment, that's actually the red line, then you see that the hazard ratios are unbiased. So the vertical dotted line is the true hazard ratio, and you see the red which is our estimated hazard ratio, is basically perfectly aligned. On the other hand, if we don't adjust the risk set, which is the blue line, we see that we actually have some bias, and that the bias gets more severe in certain settings. So in particular, we see that the bias is increasing as we move from left to right, as the proportion of patients that are truncated increases, we have more bias. And likewise, along the x-axis, we see as we move along the x-axis, our bias is also increasing. And that's because we're increasing the correlation between treatment assignment and entry time. So in other words, if we have more of a differentiation between the treated group and the control group and the extent of time to entry, the more bias that we'll have. That's what the x-axis is telling us. And then finally, you'll notice the top 3 panels versus the bottom 3 panels essentially have the exact same pattern. And what that tells us is that the direction of bias really doesn't depend on the true underlying hazard ratio. So on the top, the true hazard ratio is 0.7, less than 1. The bottom, it's 1.3, greater than 1. But we have the same pattern regardless. So the bias is really driven more by the extent of truncation and the correlation between the covariate of interest, this time treatment assignment, and entry time. And we see pretty much the exact same thing for coverage. So here we look at the coverage of 95% confidence intervals. We would hope that the truth would be included in the confidence interval 95% of the time. So that would be the coverage we want. That's where the horizontal line there is at 0.95. So that's our desired coverage. And we see with the red line that if we adjust the risk set, then our coverage is pretty spot on. We're pretty much always at the 95% nominal probability. On the other hand, though, if we don't adjust the risk set, so again, the blue line, we see our coverage kind of deteriorates, and we tend to have under coverage. And this is especially true when truncation is higher, and it also is increasing in the correlation between the treatment assignment and entry time. So really the same pattern that we see for bias with coverage. And then just like we saw before, the coverage probabilities don't depend on the direction of the true overall survival hazard ratio. So whether the truth is less than 1 or greater than 1, we essentially have the same pattern for coverage. So I think the take-home message is that when we have quasi-independence, if we adjust the risk set, just as Dr. Panejas had mentioned, then we're in good shape, and we can estimate the coefficients in an unbiased manner with correct coverage. But now I want to take just a little bit of a sidebar and think a little bit about actually what we're trying to estimate in these kind of problems, which is always going to be really important when we're thinking about inference, and specifically to distinguish what's referred to as a conditional hazard ratio versus a marginal hazard ratio. And to do that, it's maybe helpful to think about our sampling process. So of course, as I'm sure everyone knows, when we do an analysis, we always have some sort of target population, but we only observe a subset of that population. In an ideal setting, it would be a random sample. Of course, in our setting, that's not quite the case because we have this left truncation problem. So we only are observing the patients where their follow-up times are actually greater than their time to study entry. And so a conditional hazard ratio in any setting is estimated when fitting a Cox model on the sample at hand. And we say that it's conditional because we're conditioning on a given patient's covariate profile. So it might be their age, their sex, and so on. And because we're conditioning on that profile, the value of that hazard ratio doesn't actually depend on their covariate. So we kind of have a constant hazard ratio across all patients, conditional on that covariate profile. So it's kind of, you can almost think of it as like a hazard ratio for the individual. On the other hand, there's something called a marginal hazard ratio, which is the hazard ratio among patients in the entire target population. So that's, you can think of that as more like a population level hazard ratio. And in our setting, you could almost think of it as more relevant, particularly because we have this selection bias, potential selection problem, and that really we might care about the hazard ratio, not in our sample, but actually in our target population. And luckily, if we have quasi-independence, that's okay. We can actually estimate a marginal hazard ratio pretty easily using standard techniques. In particular, we can use any covariates that we observe to weight our analysis sample to look like the target population. And this can be done just using standard weights like inverse probability of treatment weights for average treatment effect on the treated. But again, this can only be done in an easy manner under the quasi-independence assumption. So then a next question is, okay, well, what happens if we don't have quasi-independence? Like Dr. Kell showed is often the case. What kind of bias do we get? It turns out in this setting, things don't work quite as well. So we'll introduce dependent truncation by setting the rho parameter I talked about earlier. We'll say that the hazard ratio is 1.5. So in other words, the hazard ratio for log entry time on overall survival is 1.5. So a longer entry time would be a shorter survival time. And what we see in this case is that regardless of whether we modify the risk set, so both the blue lines and the red lines, we actually get bias now. And the bias is not insignificant. You can see the hazard ratios are actually, the estimated hazard ratios are pretty far, can be pretty far from the truth, which is remember the dotted horizontal line. And there's also some interesting things. So that the magnitude of the bias depends on the relationship between treatment assignment and entry time, which remember is on the x-axis. And this makes sense. The more correlation there is between treatment assignment and entry time, the more entry time differs between the treated and control group. So then the dependent truncation will have a larger effect in these settings. And I didn't show this here, but the bias is also going to be increased in a row, obviously. So the larger the strength of the relationship between entry and event times, the more bias that we're going to get. So a question then is, okay, so we have bias. When this happens, is there anything we can do about it? So what are some potential strategies for dependent truncation? There's a couple that have been proposed in the literature. One that's pretty simple is to include entry time as a covariate in a Cox model. And we found in simulations that this can work fairly well. Other approaches are a little more complex. So there's what are called copula type methods and transformation methods. The transformation method, for instance, essentially what it does is it says, okay, we have dependent truncation. Can we transform our data in some way to make it quasi-independent? So it's like a transformation to induce independence. But as you might expect, there's a number of challenges with these approaches. So one, they tend to be valid only under pretty strong assumptions. For instance, in the copula method, we assume some sort of parametric forms. And the transformation methods, we assume a specific model for the way the transformation works. And in addition, you're doing this modeling only in the observed data that you have. So it's kind of only the subset of data, the observable region, if you will. And in addition, the methods are often not designed for a regression context. So both the copula and transformation methods are really meant for estimating survival probabilities in like a Kaplan-Meier setting. And in addition, the methods aren't really designed for estimation of marginal hazard ratios, which we saw previously. And this is particularly true for the approach where we want to include entry time as a covariate in the Cox model. The problem with that is if we want to estimate a marginal hazard ratio, we actually need to know the distribution of entry times in our target population, which of course is unobserved because we don't observe the target population and we have left truncation. So it's not possible to estimate a marginal hazard ratio in the dependent truncation setting in a simple way. And then I think all these methods are just more complicated to implement. They're not nearly as simple as kind of the standard left truncation adjustment that we have in this basic survival software. And I think for all of these reasons, there's a nice new paper by Arjun Sandhi and colleagues at Flatiron Health, where they propose basically simulation-based sensitivity analyses to assess the direction and magnitude of the biases caused by dependent truncation. And the idea is really, well, we can't correct for it completely and kind of have a perfect estimate. We can at least bound the potential sizes of our effects. And I think that the current state of literature, that's really the best that we have. So now just to switch gears a little bit and move kind of away from the setting where we're trying to estimate hazard ratios into one where we're thinking a little bit more about prediction, we'll change our objective. So in a typical prediction problem, we're not trying to make causal claims, but we're really trying to predict survival probabilities as accurately as possible. And when we're trying to do this, luckily, though, we can still use similar approaches. So whether we want to fit a penalized Cox model, for example, if we have high dimensional data, or we want to use some sort of machine learning method for prediction, like a random forest, a neural network, we can still modify the risk set in the same way that we can with a standard Cox model. So that kind of the same logic still applies. And likewise, just like any prediction problem with survival data, we can use standard metrics for evaluation. So we can think about things like prediction error curves, C indices, Breyer scores, and the like. The only complication, though, is since we have left truncation in both our training and our test set, we can easily get into a scenario if we're not careful about our data, where we're essentially training a model on a biased data set and then testing a model on a biased data set. And it looks like our model's great, but in fact, if we want to extrapolate to some external data set where we didn't have left truncation, which is really should be our aim, the model would clearly perform a lot worse than it did in our biased test set. And then an additional complication is that when we do want to fit these more complex models, such as the machine learning methods, they're typically not designed for left truncated survival data. They kind of will only handle right censoring. So what we found is that both fitting the models and actually evaluating them can require writing some custom code, which obviously makes things a bit trickier. So one thing that we wanted to do is to think about the extent to which predictions and specifically predicted survival probabilities could be well calibrated when we were making survival predictions. And this is sort of the analog to what we saw before when we did the risk set adjustment for a Kaplan-Meier estimation. So to try to get survival probabilities that were accurate. And the way we tackled this problem is we set up a simulation study, somewhat similar to the one that I showed previously, although maybe a bit more realistic because it was based specifically on an actual data set. And what we did is we wanted to consider high dimensional problems. So we had essentially what we called large P models with over 1,000 predictors. Because of this, we fit Cox models with lasso penalties. And we want to evaluate the survival predictions out of sample. And the reason we use the simulation-based approach is because it lets us do something we can't do in real life, which is estimate a model on a left truncated training data set and evaluate it on a complete test data set. So a test data set without left truncation. And you can see the results on the right-hand side with the figure. And essentially on the y-axis, we have the observed survival probability. On the x-axis, the predicted survival probability. And a perfect prediction would lie along the 45-degree line. And what we see in blue is that when we do the risk set adjustment, our predictions are pretty close to that line. So they're pretty well calibrated. On the other hand, what we see in red, if we fail to make the risk set adjustment, then our predictions lie below the line. That is, the survival predictions are too high. That's what we'd expect. So the kind of potential immortal time bias is inducing survival probabilities that are too high without the risk set adjustment. Another metric that we want to look at is the C index. And this can be thought of as the extent to which a model can discriminate prognosis across patients. And the reason we were interested in the C index is because it's commonly used to evaluate survival models, especially in the machine learning literature. And so what we did is we computed the C index in a test set out of sample, using the same simulation-based approach that I mentioned on the prior slide. And you can see the results on the right-hand side of the table. And essentially what we see is perhaps the counterintuitive finding that if we don't do a risk set adjustment, our C index is actually higher than if we do the risk set adjustment. And I think the main takeaway here is that you should be pretty careful using the C index with this type of data, and that it can be pretty misleading. And the reason for this is, again, if we fit a model on a data set that's left truncated, don't adjust for left truncation, we get some bias coefficients. Those could be biased in a way that makes our model seem naively to discriminate more across patients. But that's all fake, essentially. If we try to see how well it discriminated on a new complete data set, that wouldn't be the case. So again, you can't really blindly just apply prediction models with this type of left truncated right sensor data. You really need to be careful about the data you have and think very carefully about how to evaluate the models. So then just to summarize, again, to echo, I guess, what I just mentioned, it's important to be very careful about thinking about the data that you actually have, how that data is really being generated, what your estimate is, so what you actually want to estimate. And with the left truncated right sensor data, I think that's especially important. Luckily, in the cases where entry and event times are conditionally quasi-independent, the approach to take is pretty straightforward. All we need to do is adjust the risk set so that patients are only at risk following their entry date. And when we do this, that's good because the hazard ratios are going to be unbiased, have correct coverage. Likewise, our predicted survival probabilities are going to be well calibrated. Our survival estimates will be close to the truth. On the other hand, though, when we saw like the setting Dr. Kell noted, when entry and event times are quasi-dependent, then things are quite a bit more complicated. And I think, unfortunately, because there is no established single best practice, really sensitivity analyses are the best approach in that setting. So thank you very much. I'm going to turn it back over to Till.
Well, thank you very much, Dr. Inserti. So now we come to the podium discussion phase. So please, if everyone on the podium could switch on their camera, and before, while you're thinking about your questions, I just wanted to share two quick things here from the hot topic session we had 3 years ago in Prague on new versus prevalent user designs in pharmacoepi, and just wanted to highlight similarities between the issues that we discussed. Here is a paper by Jess Edwards, who presented her results at this meeting. And so this is something that is related to the topic that we have been discussing. It's more related to treatment initiation than the actual testing, but it is a part of left censoring and how to deal with it. I think when we are going to risks, it is slightly complicated due to the fact that we need to also deal with time varying hazards. In any way, if we have truncation, we borrow from the data that we of those where we have observed the data, and I think the speakers clearly highlighted the assumptions behind this borrowing that we're doing in such a setting. So now I stop talking, and it's up to you to ask the speakers questions. I will try to look at the chat right now. Other than the question about how to implement this, I think that has been addressed by now. I don't see anything, but please don't be shy. Wow. Don't speak up all at the same time.
I can ask a question if
sure. If go ahead.
Thinking, I know I mentioned this in our sort of prior discussions, but I guess I'm wondering if anybody has thoughts on the additional complexity around a progression-free survival endpoint in thinking about left truncation. This is one of the benefits of these detailed clinico-genomic data sets, is we can get information on cancer progression, which is one of the things that tends to be missing from less rich data sets. But questions like, even in the absence of dependent left truncation, like, do we do the risk set adjustment for progression-free survival, is, I think, not, it's not obvious. So I'm wondering if anyone has thoughts on that point. It's additionally more complex if there's dependent truncation, and maybe it's a whole separate workshop, but it comes up with some frequency. Sounds like it may be a separate workshop, so that's good to know.
I think that Dr. Pedras, did you say that you had done some? I thought I saw in your slides that you had done some analyses with PFS.
No, we are working with Ken, trying to figure this out. So sharing the same concerns. It's a little bit of a different problem because patients who die prior to sequencing, right? You don't have any of that information. patients who progress prior to sequencing, you still have their information. So it's a different scenario. And I think we may need to do a full-blown simulation study to make a recommendation. I don't think it's as straightforward.
Yeah, that's people, that would be what I would think as well. One thing I had thought, I mean, maybe it's a potential route to take, is to think about it in like a multi-state modeling framework, where you actually separately model the transition to progression and the transition to death, because then I think it can at least help you disentangle the problem that was just mentioned, which is that you know, having information, not having information when patients die before their test, but having it, they have it before their progression. So haven't done anything on that. It's just you know, a potential idea.
We've actually started on that, and maybe that would, yeah, we don't have any results to share, but that's sort of the path that I think we think might be the answer to, might be an approach that's reasonable. It's not so straightforward either, though.
As is always the case.
Imagine it may be a general problem in sort of broader health services research around, like particularly in the cardiovascular disease setting, which is so prone to composite endpoints, where some of them may be possible before cohort entry and some may not. So that might be a generalizable result if we can get that done.
Okay, now we have a question from Dr. Lund here. It seems that one important part of this issue is the disconnect between the study origin, starter follow-up, and collection of some important information, genomic testing. Are there efforts to try and better align these two timelines? Perhaps the clinical issues context dictates this, but perhaps the speakers to discuss this.
Yeah, so just do a prospective study is the recommendation there that's behind that question, and it makes a ton of sense. I think the reason it sort of hasn't happened in that way is a matter of sort of the convenience sampling dynamics that go into creating at least some of these data sets, particularly in sort of a more real world setting. But yeah, that would do it.
But a follow-up question here. I mean, you do have the clinical data from everyone in your setting. It's just that due to whatever technicalities, you only see the data of those that have the genetic testing. I mean, the EHR has the data of everyone. It's just that technically you're restricted to seeing the data of those that have the genetic testing. So if you had the entire data set, including those with genetic testing, but also those without, you could do some more informed analysis, because you could look at all these selection mechanisms that will create problems.
Absolutely, you're absolutely right, except that these data are manually curated. So there's a team of people that actually go through the electronic health record and curate using a standard data model. And we have selected those that, or, you know, the team has decided to select those that have the genomic criteria fulfilled. It would be a project that would be at least double or triple in scale if we curated all of their, but that would allow for different analyses. And
because then even retrospectively, we could
Right.
identify the entire cohort, and then we would be able to do a much more informed analysis. Can everyone see the chat? I mean, I'm certainly not the best person to read the chat. So there's a question from Dr. Bates here.
So I think actually maybe in response to a couple of these questions, even with respect to the issue of, can we just collect data on non-sequenced patients to inform some of this? And I've thought about that as well. In some ways, you sort of can go down I think you can go down a kind of a goalpost moving rabbit hole there, because if we're still dealing with an EHR data set, then the issues around whether and when patients made it into an EHR that we're looking at comes up, just like the issue of whether they had genomic testing and when. In terms of the question around timing of genomic testing and how that varies in different contexts, academic versus community cancer centers. I haven't seen work on this. I think it would require collating data from pretty different sources, which would be an interesting project, but might be kind of substantial. I mean, I think there's probably variation even just within academic centers. And that might be something that, or among academic centers. And that might be something we could try to quantify.
Okay, everybody's reading Dr. Meyer's question here. I mean, for me, this is all related to what predicts testing, and you can only assess that if you have the complete data. I mean, otherwise you're always left guessing what the selection mechanism is. I get the point about the EHR not being complete, but there may be setting where EHR is linked with claims data where you might actually get back, or with SEER data. That could allow to look at these selection factors and the timing thereof also. I mean, how quickly you are getting the data after being diagnosed or starting the therapy.
Yeah. I mean, I think with all of these, if you knew that practice payer level influences were enough to completely explain the differences in testing patterns, then sure, you could control for them and your problem would be solved. But you, again, like as was just mentioned, you can't know that for sure unless you have access to the non-truncated data as well.
Dr. Meyer's question here also touches on an issue which is probably important and under-recognized, and that sort of hasn't been the focus of the workshop today, but namely, like in a clinical trial setting, when you use a progression-free survival endpoint, there are specified time points when you have to look for progression. In an observational data context, whether and when you're looking may itself be correlated with risk and other clinical features. Yeah, I think that's an important issue. It's probably a little bit distinct from the truncation issue, but it's underexplored as well, as far as I know.
Is there a setting where you do not have anyone entering early after your T0 that you're interested in? Because your method requires that you borrow from some people who are not left truncated.
So is the question whether there's ever a setting when there's no delayed entry?
Yeah, I mean, if no one gets genetic testing at the start of their therapy, for example, then your method depends upon there being some people and you borrow their data for your model.
Yeah, I mean, effectively, you can only estimate a hazard, or say a survival probability, beyond whenever the first patient enters the study.
Yep.
And you have no information prior to that, without assuming some parametric type of assumption.
I think it may move in the opposite direction, where depending on certain clinical scenarios, and Dr. Keel could clarify if there are certain settings where maybe there are more patients actually getting their profiling done at the time of diagnosis. So I think there'll be, you know, as we move forward, there'll probably be more alignment just naturally as there's insurance coverage, as there's more access, and the cost of these tests are decreased, and it moves more into a community practice standard as well. But I don't know if that's the case for all cancers, you know, all cancer types, or just really where we might have need the information for treatment decisions. But where we do need the information for treatment decisions, I think that testing will move up in the patient's trajectory closer to diagnosis.
Yeah, that will reduce the amount of the problem. But I mean, maybe it's now we have 4 minutes left time to. I'll just propose my take-home message, and then you chime in. So for me, is that the most important message you need to know about this. This is the big E in genetic epidemiology. You need to think about these things, and I think this workshop was clearly successful in highlighting this issue. And based on that knowledge, you still need to decide whether it matters in your setting, and if so, you need to deal with it. And thanks for proposing. I think we proposed some methods that how to address this, and you got some names to contact if you're lost there. So that's my take-home message. Maybe leave some time for others to refine. Don't be shy. We have 3 minutes left.
I would agree with that. I think the only thing I would add is that I do think it would be worthwhile for research to spend a little more time thinking about the best ways to handle these dependent truncation problems. I think there is a literature on it. It tends to be very, very technical and maybe not focus so much on applied problems. So I think if you could kind of bring the technical with the applied problems together, we could maybe propose methods that are a little more fit for purpose. So yeah, I think that would definitely be the area to focus on the methodological side.
And of course, have code attached to it.
Yeah.
Yeah, I mean, in pharmacoepi, we've been thinking about left truncation prevalent users versus new user designs for quite a while now, and I think we got much closer to coming up with the conditions or the implicit assumptions that you make when you look at prevalent users, and so I think these two things are related, and very often it's driven by availability of data, obviously. So it's a point well taken. Oh, are presenter slides available for future reference? That I do not know. I would assume that this session is recorded and you can watch it whenever you want to. That's my understanding. Amy, do you know? Okay. Amy says the presenters were responsible to upload their slides if they want to share them. So just leave it up to the presenters, and otherwise the session has been recorded and you can watch it. Okay, we're getting close to the end here. I would like to thank you all for joining this workshop. I would like to thank the 3 presenters for their excellent presentations, and I look forward to seeing you again in future sessions. Take care, everybody.
Thanks very much.
Bye-bye.